Dr. Nidhi, can you share your that first PPT?
Okay, sir, I'm trying. Wait.
Hi everyone, is the presenter here?
Yeah, she's trying to open the presentation.
Oh, okay. Hi sir.
Yeah. Hi.
Oh, it's not opening, sir. It is support. It is showing unsupported content.
Dr. Dhanya, can you try to open it?
Sir, the basal ganglion anatomy,
Yeah.
sir.
Yes. Neuroanatomy.
Yes, sir.
नहीं विकेट के साथ रखो
Okay. So can you share that? Dr. Ramkrishna?
सर बोलो जी.
Can you start recording? Then we'll start. So today's moderator, Dr. U.M. Srinivas. And Dr. Somesh Singhal. Today's moderator are Dr. U.M. Srinivas and Dr. Somesh Singhal. And today, Dr. Nidhi and Dr. Dhanya. And if anybody wants to say something, they can unmute themselves. And it is an interactive session on first neuroanatomy, followed by this history and examination pattern in a case of akinetic rigid syndrome. So over to you, Dr. U.M. Srinivas and Soumya madam. And today, Dr. Nidhi, you will start, then followed by Dr. Dhanya. So
Yes sir, I think we can start.
Yeah.
Yes, sir. Yeah.
So, Dr. Nidhi, you just see some slides where there is more focus on diagrams and
Yes.
pathway. Okay. Okay, Dr. Dhanya, can you make it slideshow? Slideshow. This top means bottom fifth. Okay. Bottom fifth button. Slideshow. Yeah.
Yeah.
Okay, Dr. Nidhi, you can start. Next slide. Dr. Nidhi, you can start.
Hello.
Yeah, go
Yes,
ahead.
doctor. Please go ahead. Go ahead.
Okay. Good evening, sir. So today we are discussing about the anatomy and components of basal ganglia circuits and its related neurotransmitters, various loop associated with basal ganglia, then pathophysiology of movement disorder associated with basal ganglia diseases, and then blood supply of the basal ganglia. Next.
Okay, we will give 15-20 minutes for this. Then
Yes.
next, after that, half an hour. Then next half an hour. So by 8 o'clock, we should finish.
Yeah.
Yeah, okay, sir.
This presentation, move it slightly quicker. Okay.
Yes.
Yes, sir. So basal ganglia consist of various nuclei, including caudate nucleus, then putamen, globus pallidus. Globus pallidus has two parts: globus pallidus interna and externa. Then thalamus, subthalamus and substantia nigra, pars compacta and pars reticulata. This previous slide, please. Previous. So the combination of putamen and caudate, they both are called as striatum, whereas lentiform nucleus is made up of putamen plus globus pallidus, and the combination of all the three, caudate, putamen, and globus pallidus, is called as corpus striatum. Next slide. So basically, we know the striatum is made up of this putamen caudate. So it has two parts: dorsal striatum and ventral striatum. Dorsal striatum has putamen and caudate, and ventral striatum is consists of nucleus accumbens, which has its role in mesolimbic pathway. Then coming to globus pallidus, which has two parts: globus pallidus interna and externa. Then coming to substantia nigra, which has two parts also: substantia nigra pars reticularis and pars compacta. Pars reticularis has more function in the pathways of the basal ganglia. Then coming to subthalamic nucleus, which is also a part of this basal ganglia connections. Next slide. So this overview of the motor system. So basal ganglia and cerebellum both has its connection with the upper motor neuron system. So basal ganglia decides in decision to movement, direction of the movement, amplitude of the movement, and emotional body language associated with the movement. And cerebellum decides through environmental cues, vestibular information, and proprioception in deciding the coordination of the movement. The pathways from the basal ganglia and cerebellum goes to the upper motor neuron system, and through corticospinal tract it comes to the lower motor neuron system, and then the movement happens. Next. So here we can see striatum, which is made up of caudate and putamen. It receives all the input from the cerebral cortex. So this striatum is the input nuclei. Then striatum mainly outputs to globus pallidus interna and substantia nigra pars reticulata, and also globus pallidus externa. Globus pallidus interna and substantia pars reticulata both in direct and indirect pathway, and globus pallidus externa has role in only in indirect pathway. Then principal projection of the basal ganglia, then back through thalamus, then it goes back to the cortex, mainly to the motor associated areas. So basal ganglia also provide output to thalamus, superior colliculi, and pedunculopontine nucleus. To thalamus, influencing the motor, sensory, and cognitive processing. Superior colliculus for influencing the eye movements, and pedunculopontine nucleus for postural control. So we know that the lesion in the pedunculopontine nucleus is associated with falls and postural instability. Next. Now there are the two types of cells in the this striatum. One is median spiny neurons, which consist of major population. 95% of the neurons in the striatum are medium spiny population, spiny neurons, which are mainly GABAergic and which have D1 receptors through which they modulate the direct pathway, and D2 receptors which they modulate the indirect pathway. Then second is the striatal interneurons, which are modulators. So these striatal interneurons are tonically active neurons which releases the which acts through cholinergic pathway. Then fast spiking interneurons which mediates the GABAergic pathways. Then low threshold spiking interneurons through GABA and nitric oxide, and tyrosine hydroxylase interneurons, which mediate through which releases dopaminergic pathways. Next. Clinical relevance of the striatal cell types in various movement disorders. So we know that in Parkinson disease, loss of dopaminergic inputs are there. So there will be underactivity of indirect pathway and overactivity of direct pathway and overactivity of indirect pathway, which leads to hypokinesia and rigidity. And through cholinergic interneurons, which becomes overactive, they contribute to tremors and rigidity in patients of Parkinson disease. So we use anticholinergic drugs to restore the balance of these cholinergic interneuron pathways. Then second is Huntington disease, where early degeneration of indirect pathway leads to chorea, that is hyperkinetic movements, and later on widespread striatal atrophy leads to akinesia in these patients. And dysfunction of cholinergic interneurons leads to cognitive and psychiatric symptoms in Huntington disease patients. Then third is dystonia, tics, and Tourette syndrome. Then altered median spiny neuron activity and interneuron disinhibitor contributes to involuntary movements in the dystonia, tics, and Tourette syndrome. Next. Next, I'm not able to see the next slide. Now coming to next is globus pallidus. It is made up of two parts, interna and externa. Interna has involvement in direct and also in indirect pathway, and externa has involvement only in indirect pathway. The neurons are high tonic firing rates and GABAergic neuron, that is inhibitory in globus pallidus. Next. Now, subthalamic nucleus, it is also a target for deep brain stimulation, DBS in idiopathic Parkinsonism disease. It has a major role as in indirect pathway. Next. The role of substantia nigra pars reticulata and pars compacta. So substantia nigra pars reticulata is having GABAergic neurons, which is a part of output of the basal ganglia along with globus pallidus interna. And substantia nigra pars compacta, it has neuromelanin containing cells which releases the dopaminergic system, dopamine, and it facilitates the direct pathway and suppresses the indirect pathway via D2 receptors. Next. So coming to one more slide. Next. one more next. Coming to direct pathway. See, so we all know that the stimulus from the cortex comes to the into the striatum, and the pathway is here facilitatory through glutamate. It stimulates the glutamate. It stimulates the striatum, and from striatum, the impulse goes to the globus pallidus interna and substantia nigra pars reticulata. So striatum is the input nuclei, and globus pallidus interna and substantia nigra pars reticulata is output nuclei here. And the striatum inhibits this globus pallidus and substantia nigra, which further inhibits the thalamus. So since this striatum inhibits the globus pallidus and substantia nigra, the further inhibition is lost. So thalamus can facilitate the cortex through glutamate. So direct pathway is a facilitatory pathway, and its dysfunction leads to hypokinetic movement, that is bradykinesia and rigidity, seen in idiopathic Parkinson disease. Next. So direct pathway is excitatory to the motor cortex. So it facilitates the motor program required for current task. Next. Now, next is the indirect pathway. So here we have globus pallidus externa as well as thalamus also. Apart from this striatum and globus pallidus interna and substantia nigra pars reticulata. So impulses from cortex goes to striatum, which is facilitatory through glutamate. Then from striatum to it comes to the globus pallidus externa. Globus pallidus externa say it goes to the subthalamic nucleus and also to the globus pallidus interna. Both are inhibitory. And from the globus pallidus interna and substantia nigra pars compacta, the impulse goes to the thalamus, which inhibits the thalamus. Now the thalamus is has been inhibited, so it gives less facilitatory input to the cortex. So this pathway, overall indirect pathway, is inhibitory to the motor cortex, and whenever it got we have any dysfunction in this indirect pathway, we will have the consequences of hyperkinetic movements. So hyperkinetic movements like chorea, dystonia are due to dysfunction in the indirect pathway. Next. And one more is the hyperdirect pathway, where we do not have striatum, and we directly receive the impulse from cortex to subthalamic nucleus, and from subthalamic nucleus to globus pallidus externa and interna, and then to thalamus. So we can remember this pathway is also inhibitory, like indirect pathway. It is inhibitory to the cortex. We have covered all this.
So, doctor, I just wanted to point out something. You are right. Yes, indirect pathway and direct pathway dysfunctions lead to the hyperkinetic and hypokinetic. But you have to remember that direct is actually facilitatory for activity. So direct
Yes,
needs to
sir.
be normally active, and
No,
indirect needs to be inhibited for normal activity. So when
normal activity.
so when the indirect inhibition is reduced, then it becomes more. If it's more active, that's when you get Parkinson. So that's why
Yes,
I think there's D1, D2 difference in receptor signaling from the the substantia nigra compacta. Actually, that is
yes,
where the pathology of Parkinson lies.
yes,
So
sir.
if it
So
is
direct,
activating the D2,
yes,
yeah,
yes, sir.
exactly. So if it's
Direct
D1
is
activated,
given,
then it
and
becomes
yes,
direct
sir.
pattern.
Yes, sir.
And if it
Direct
becomes
pathway
D2,
is
then
D2 is
exactly.
the indirect pathway,
Yeah,
sir.
so
Yes,
D2 is inhibitory. So if
yes,
that's
sir.
when, because the SNC is loses its dopamine energy. So that's
Yes,
when the
sir.
pathway varies. So your direct becomes inhibited and the indirect becomes activated more. So that's why you get, so that action, normal activity is lost. That's why you get
Yes,
this so the suppression of the indirect is lost and activation of the direct is lost. So both
yes,
of these are lost together. That's why you get Parkinson. Yeah.
yes, sir. Yes, sir.
Yeah.
Okay, sir. So D2 suppresses the indirect pathway. Now, cholinergic modulation of the direct and indirect pathway. So we know that the cholinergic neurons are there in the striatum, which inhibits the striatal cells of the direct pathway and excites the striatal cells of indirect pathway. So the overall effect of the cholinergic interneurons is to decrease the motor activity. So acetylcholine turns down the motor activity, and dopamine turns up the motor activity. Next.
So one more thing before going, yes. Yeah, it's
Yes.
mentioned here. Yeah, please go ahead. I finished this and we'll talk about it. Yeah.
So basal ganglia and motor pathway. So there are two basic theories for the motor control. One is theory of lateral inhibition by medium spiny neurons, which is important in selection of competing motor programs. Each medium spiny neurons has numerous inhibitor GABAergic connections with the neighborhood MSNs, allowing to increase the signal to noise ratio of striatal output. So, and second is the feed forward model, which is inhibition by this fast spiny neurons in the striatum. Then their role and in reward and language processing. So ventral striatum nucleus accumbens, it has projection to ventral pallidum, and it has a role in limbic motor integration. And ventral pallidum also has its role in reward, sex, social affiliation, and drug abuse, etc. I will be covering these topics, the pathways in next upcoming slide. And then striatum, last. Striatum has important role in language processing and word retrieval and syntax. Then basal ganglia, as we all know, have connection with cerebellum, and it has a bidirectional connection through dentate nucleus and has a role in movements, coordination of movements. Then this coming to basal ganglia circuit. So we all know. Next slide. There are four loops: motor loop, oculomotor loop, cognitive loop, and limbic loop. These four loops are there, which are concerned with various functions of the basal ganglia. So first is motor loop. Next slide. So from in motor loop, the impulses from the cortex goes to putamen, and from putamen to ventrolateral globus pallidus, and from the globus pallidus to thalamus. So this is the motor loop, which is responsible for planning, initiation, and storage of motor programs and fine tuning of the various movements done by our body. Second is the oculomotor loop. So it is responsible for saccadic eye movement. So here impulses from frontal eye field and posterior parietal cortex, they goes to the caudate nucleus, not putamen. Caudate nucleus has a role. And then from there to the output nuclei of the basal ganglia, that is globus pallidus interna and substantia nigra pars reticula, and from there to thalamus, and again to the frontal eye field. So this is the oculomotor loop, which is essential for the control of saccadic eye movements. Third one is the cognitive and
One thing, in last slide, there is the oculomotor loop. The important thing is superior colliculus.
yes,
Okay,
ma'am.
there it will go
Yes.
down to your this third, fourth, sixth nuclei, and that then it will control the saccadic movement. So that is important.
Yes, ma'am. Next is cognitive and associated loop. So from the dorsolateral prefrontal cortex, the impulses go to the caudate, and from there to the globus pallidus interna and substantia nigra pars reticulata, and from there to thalamus, and then again to dorsolateral prefrontal cortex. So it has a role in the planning of complex motor activities. So whenever a new task has been practiced and well learned, a activity in the associated circuit later on decreases, and the motor circuit becomes actively increases. So we know that in the procedural memory, we have more of the role of basal ganglia and cerebellum. Next. Then limbic loop. So limbic loop starts from orbitofrontal cortex and anterior cingulate cortex, and then it goes to the ventral striatum, nucleus accumbens, and from there to ventral pallidum, and from ventral pallidum to the thalamus, and again to orbitofrontal cortex and ACC. So it has a role in the motor expression of the emotions. This is the limbic loop. Next. These are the four
So
loops.
1 second. 1 second. So just
Yeah. Yes, sir.
if you can actually, it is very useful if you can actually understand why these loops make sense. So when you go back to those loops, we're talking about all these four loops, right? So you're talking
Yes.
about why it is important is where does the pathology occur? That is why when you know that, you will never forget the loop. So in Huntington's disease, your oculomotor loop is the first which gets affected, which is why your eye movements are affected very early on in the disease.
Yes, sir.
And also you'll get the dorsolateral prefrontal cortex being affected. So
Yes,
this the prefrontal loop getting affected. So when these two loops are affected, that's why you get more of cognitive impairment as well as the initiation of saccades being affected. So when this, but because the frontal eye fields are important for the initiation of saccades. That is where the role is. So you look at the saccadic pathways. So that now you have to cross fields in neurology. You go from here to neuro ophthalmology. So you think
Yes,
about how your saccade is initiated. The initial impulse has to come from your cortex, because the cortex tells you that's your frontal eye fields. That's when they tell you, okay, you need to look to this side. So this pathway now is being modulated via the basal ganglia. That is,
yes.
and this part, when this loop is impaired, that is why your initiation of saccade is impaired first in Huntington's, and same
Huntington's.
with in Huntington's. So this pathway is where the first pathology occurs. So and you can see when that happens, and also the prefrontal is again an anterior caudate. This again is passes through the caudate. So these two are through
Yes,
the
sir.
caudate. We all of, if you can remember in Huntington, we all look at caudate
Yes,
atrophy.
Korea.
So the
Yes, sir. Korea.
caudate is the one which is atrophied. Yeah. So
Yes, sir.
caudate atrophy is is the radiological marker in Huntington's. So
Huntington
we have
disease.
caudate atrophy. These two pathways are the ones which are affected first. That is why those two are the clinical correlates that you get. So that's how we, that's if you remember that, it's very easy to remember these pathways also, knowing that okay,
Yes,
this is how the disease is actually going to progress. And
yes, sir.
the same goes for other pathways as well. And again, so when in Parkinson, if you're thinking about it, the dorsolateral prefrontal, this is why you get initial subcortical processing deficits and cognitive impairment in Parkinson and Parkinson plus syndromes. So even without
Yes, sir.
cortical involvement. So these are,
Yes,
so
sir.
when you know these pathways, it'll be extremely useful to be able to predict what the disease, what the patient is going to have. That is why these pathways actually matter.
Yes, sir. Yes, sir. Hmm. Next. So, sorry, last slide.
No, no, okay, we
हाँ,
can go more
हाँ,
forward.
ठीक है सर, ठीक है सर. So we know dopamine is secreted from the substantia nigra pars compacta.
Okay, next slide.
Next slide.
Next.
No sir, last slide. So there are actually 5 dopaminergic pathway: the nigrostriatal pathway, mesolimbic pathway, mesocortical pathway, tuberoinfundibular pathway, and fifth pathway. First is nigrostriatal, which is coming from substantia nigra pars compacta to the striatum. So this nigrostriatal pathway, it subserves the motor function, that is learning new skills. So motor symptoms of Parkinson disease and adverse effect of antipsychotic drugs are mediated through this nigrostriatal pathway. Second is mesolimbic pathway, which is coming from ventral tegmental area to the limbic system, that is amygdala, piriformis, nucleus accumbens, and hypothalamus, and the other part of the limbic system. And it subserves the emotional reward reinforcement learning and pleasurable activity through dopamine. And it is implicated in drug abuse, gambling, and impulse control. this mesolimbic pathway, and these antipsychotics blocks the mesolimbic pathway to decrease the positive symptoms of schizophrenia. So this antipsychotic effect is also mediated through mesolimbic pathway. And the third is mesocortical pathway, which is also started from ventral tegmental area to the prefrontal cortex, dorsolateral and ventrolateral prefrontal cortex. It subserves the cognition, working memory, emotional and affect part. And antipsychotics may worsen the negative effect of schizophrenia via this mesocortical pathway. The fourth is tuberoinfundibular. Next slide. Tuberoinfundibular, from the arcuate nucleus of hypothalamus, it goes to the median eminence of pituitary, and through here, dopamine inhibits the prolactin release. So dopamine blockade in this pathway through antipsychotics can lead to hyperprolactinemia and galacturia. And the fifth pathway is thalamic dopaminergic pathway, which is from the dorsal posterior hypothalamus to the thalamus, and it subserves the sensory perceptions and autonomic functions. It is implicated in restless leg syndrome, which may cause abnormal visceral or muscular sensations at the time of night, especially seen in Parkinson patients.
So, Dr. Dhanya, one thing, Dr. Nidhi, one thing.
Yes,
Again, you need to understand the underlying importance at why you are studying this. Okay. So, if you go back in the first slide, so there are actually four paths, four mainly, and then the five pathways in which we study the dopamine. So, the one that commonly studies an agrostriatal that we study from our MBBS area. So, this thing is important in which we study the Parkinson pathophysiology. If you give an antibiotic, so there will be an impairment in the this pathway, and you will develop a Parkinsonian or extrapyramidal side effect. Okay, but why is we are studying? Because all the treatment of Parkinson is going around this mechanism, or going around only the dopamine mainly. It is dopamine. Okay, so whenever you are replenishing the patient with dopamine, so it won't only act over this pathway; it will go other places also.
Yes, ma'am.
Similarly, the underlying pathophysiology, mainly it is nigrostriatal, but the Parkinson patient, if you go back in the history, you will find that they have actually a significant problem of a RLS. The preceding RLS is high number of patient is there. And mostly those patients who are developing this vascular Parkinson, or in the later time, those who are developing an ischemia for a chronic time, they develop RLS only in the one limb.
Yes, ma'am.
Yes, so that's why these pathways are important. And same when you are giving the dopamine. So because there is a dopamine is going into mesolimbic as well, mesocortical as well. So these patients develop an improvement in cognition, but along the same time, as the mesolimbic is involved, they will go for pathological
gambling, pathological gambling, and impulse control disorders.
That's why need not to mug up these pathways or the previous that this basal ganglia circuits. If you just look at one patient of Parkinson and you try to dissect out that what complaint this patient is having, and okay, then what structure will be involved and what treatment we are giving, and what part is it is getting act. So those coordination you will develop better by time to time. So whenever you are seeing a patient in OPD, this is my personal advice for next 1 month. Whenever you are attending OPD and seeing a patient, try to draw pathway at the same time, and then try to think that okay, I'm prescribing this drug, it is going to act at this place. So then you will learn better. Okay.
Yes, ma'am. Yes, ma'am. So motor behavior. So the balance between the direct and indirect pathways will be causing disorders. So hypokinetic disorder will be caused by the insufficient direct pathway output and excess indirect pathway output. And whereas hyperkinetic disorders will be caused by excess direct pathway output and insufficient indirect pathway output, as we have already discussed. So, in Parkinson disease, the pathology starts at the substantia nigra pars compacta, and there will be it will lead to loss of dopaminergic stimulation. Next. So as we have already discussed the direct pathway, and I will not be talking about it. Next slide. Next. So major motor symptoms and their pathophysiology. So bradykinesia will be caused by decrease in dopamine, which leads to decreased activity in direct pathway and increased activity in the indirect pathway. Second is rest tremors, which is due to dysfunction of cytopallido-thalamocortical circuits or cerebello-dentothalamocortical circuits. The third is rigidity, which is also caused by similar to bradykinesia, decrease in dopamine activity. And then coming to postural instability is due to altered cholinergic transmissions in pedunculopontine nucleus and cerebral cortex. So pedunculopontine nucleus has its role in postural instability. And then coming to freezing, it is due to deficiency of noradrenergic adrenaline in the locus ceruleus. So due to locus ceruleus degeneration, it leads to deficiency of noradrenaline and it leads to freezing in patients of Parkinson disease. Next. Now coming to these non-motor symptoms, so autonomic dysfunctions like orthostatic hypotension, sexual dysfunctions, incontinence, urinary incontinence, sweating dysfunctions, drooling and GIT dysfunctions. It is due to post-ganglionic catecholaminergic autonomic neuron dysfunction due to alpha-synuclein deposition in the autonomic nuclei, Lewy body deposition. Then cognitive impairment is more seen as executive dysfunction as compared to memory. It is due to frontostriatal dysfunction, that is cognitive or associated loop. Then REM sleep behavioral disorder is due to brainstem, that is mainly in pons region and medulla. Brainstem Lewy body pathology. It is seen in sublateral dorsal nucleus of the pons and medullary nuclei of the medulla. Then neuropsychiatric manifestations, that depression, apathy, psychosis, impulse control disorders, and gambling issues are due to mesolimbic pathway involvement. And it could be drug induced, that is in dopamine agonist drugs like pramipexole, ropinirole, rotigotine, etc. Next. Hyperkinetic movement disorders, it is due to the chorea is due to loss of GABAergic neurons in the indirect pathway, which leads to excessive movements. Then dystonia is due to...
We can skip this next.
Okay, sir. Okay, sir. So we can skip.
Yeah, then we can go to examination, this history taking, symptoms and signs.
Okay. So Dr. Dhanya will be covering that?
Yeah, you can cover this history part. She will cover examination part.
Okay, sir. Okay. So Dr. Dhanya, can you please play those slides? I am not able to play.
That slides are not available. Just you have to discuss. Examination slides are available.
Okay, sir. So,
Yeah.
Okay, sir. It will be discussion. Okay, sir.
Yes.
So in history, we have to ask about the symptoms of slowness or tightness of the body. So basically, we have six symptoms. Bradykinesia, tremors, uh, tremors, rigidity, bradykinesia or akinesia, postural instability, and then FF, freezing, and then this flexed posture. So we can ask about any slowness of movements, and we can ask about the patient partner, about the slowness, about the their change in any posture or their tremors. Means patient is having any tremors while doing activities. And
Dr.
sir,
Nidhi, yeah,
yes,
one second. So the thing about remembering, the most important thing about tremors is very rare the patient will complain about the tremor. The tremor in Parkinson is a resting tremor. And most
Yes.
of the time, they will not complain of the tremor at all. The tremor will be noticed either by the doctor or by some
Yes.
family member and said, okay, your hand is shivering. But they're saying, no,
Okay.
it's not bothering me. It's because unless they're coming to you very late in the disease with a very severe tremor, it's
Yes.
unlikely the patient actually complains of the tremor being a problem. So,
Mm.
and again, most of the time, the presentation will be that yes, they have become slow. Slow is very common. Other
Yes.
issues we can have patients like difficulties dragging their feet. That becomes a very common thing. They keep falling over. That is again, recurrent falls is something you have to ask. Is
Yes.
something they will come to you with. Another
Ah,
complaint is just simply back pain. Many a time they just
yes,
have say,
sir.
I'm back pain. I can't walk properly. That's all
Yes,
they
sir.
have. So it's
And one thing
just
more I want to add, this frozen shoulder. Matlab, I have seen
yeah.
2 or 3 patients of this frozen shoulder. Means they come with the complaint of this pain in the shoulder and restricted movement of the shoulder. But whenever we examine the patient, like they have mask like face and they have slowness, and on further matlab asking the question, leading question, they accept that they have slowness of movement. So frozen shoulder.
That's true. That's true. I've even had patients come to me after they got the orthopedician gave them steroid injections, didn't improve, and then he said, "Okay, just see the neurologist." So yeah, so that does happen with periarthritis of shoulders, very common. Somebody's asked
Yes.
why back pain. Unfortunately, I'm not exactly sure why the back pain, but most of the time it is due to rigidity. So and they respond very well. The back pain actually disappears once you start them on some sort of dopaminergic medication.
Yes.
And so lot of unexplained pains. And so when you ask about slowness, it is sometimes useful because patient will they will think it is just because they're getting older. So you're getting them to agree that they are slow is very hard. You will have to ask them. You say if they are say somebody who's cooking, you can ask them, okay, how long does it take you to cook now? The same
Yes.
thing if it used to take you half an hour, is it taking you more time? Then they will slowly come out, yes, it now it is like double the time that I'm taking. So those are
Yes.
things you can ask them and they will tell you, okay. So many a time they will not say I'm slow. They say, okay, I'm just getting old, so I'm getting slow. That's all they will think. So it's getting that question out, you will have to get into what they are doing. So if somebody who goes walking regularly, just ask them how
Yes.
long does it take for you to finish that usual round? Is it taking
Yes.
longer now? And again, another
Yes.
thing you have to ask is whether their handwriting has changed. Many times,
Yes.
so that
Exactly.
might be the first question as well. So
Mm.
those are
Yes.
all things that you can ask them. So try to see what the patient's job is. Then you can actually ask them, okay, something relevant to that. That will give you a proper answer. Somebody is going to just sit at home, retired. They won't even bother about their handwriting because they don't have to write anymore. So you won't get
Yes.
that question answer from them. So we find out what the patient's. That's why the patient's background becomes relevant. Then you can ask them what the relevant questions to them. Then you can find out if they're actually being slow.
Yes, sir. And we can ask about the change in voice, sir. So the voice
Yes.
has become slow, and it has become hypokinetic, means more slightly monotonous, slow, and low volume.
Yeah,
Uh,
the low volume is what usually people complain of that. Especially the five will say, I can't hear him anymore. So that will be
yes,
the
sir.
usual question. So if we can get that, then
Mm.
yes, that tells us the voice is being affected as well.
Yes, sir.
Yes.
And uh, Mm, and more still we can ask about this, sir, about their non-motor symptoms. Means it could be leading questions like for patients we can ask about the sleep-related issues, like if they have any REM sleep disorder, or we can ask about the loss of smell, or we can ask about the constipation part, because since most of the patients have constipation due to enteric plexus involvement, and we can ask about the nocturia and frequency of micturition, and we can ask about the sweating patterns, whether they have increased sweating or decreased sweating, or we can ask about erectile dysfunction.
Okay, so these are all very relevant things. Erectile dysfunction, again, remember this, it's an elderly, sometimes we may not get the right answer. The other
Yes,
thing
sir.
is, when you're asking about sleep, how would you ask for REM sleep behavior? So what history would you ask the patient?
Hmm. Sir, we will ask whether there will be any violent or flinging moment after 1.5 hour or around 2 hour of the sleep. which could lead to the injuries to the patient and also as well as to the partner.
It's very hard to get such a very good answers. You will never get such good answers from the family. And remember that when you are asking the question, find out who's. You have to see who has come with the patient. If the son or daughter has come, they will not know if the patient is having such problems. And many
Yes.
a time RBD will not be so violent. It can be mild as well. So best thing to is find out if he talks in his sleep. That'll be the easiest thing. So if they're
Oh,
talking in sleep, that will be a good sign. Okay. Or then there's slowly, if you can ask, yes, sometimes he moves in sleep, moves his hands in sleep as if he's acting, then they slowly come out. And if the vet partner is very important. So wife or husband, yes, they will know. Otherwise, if you ask anybody else, they will not. And if you ask the patient, obviously he will not know. So not very
okay.
useful. And the patients can also have a lot of vivid dreaming. So that is something
Yes,
you can
sir.
ask.
Yes.
Excessive dreaming, especially if it is scary.
Hmm.
If that is there, that is a good clue that it's probably dealing with a synucleinopathy. That is why that is important. That's why you don't get synucleinopathies are the one you have all these dream and RBDs which are happening. So actually this might not be in all patients, but the actually more common sleep problem in Parkinsonism is early morning sleep fragmentation. So that again you'll
Yes,
have to
sir.
ask them. So whether they
Early
keep
morning
getting up
sleep
early in the
fragmentation.
morning, sleep fragmentation. Whether they
Yes,
wake up,
sir.
keep getting up early in the morning and then have finding it difficult to go back to sleep, or they keep waking up 2 or 3 times, especially in the early morning. That's again a good sign.
Yes, sir.
One more thing, Deep. You actually, we are taking this history to, this is very important that in the early part of the illness, we need to differentiate these patients from the atypical or the secondary Parkinsonism. Okay.
Yes,
So,
ma'am.
along with the classical Parkinson disease history, you have to take the history of atypical as well. That is
Yes, sir.
early during initial onset of illness, or if there is an early involvement of a urinary complaints or this autonomic dysfunction, whether they are
Hmm.
having couple thing or not,
Yes,
recurrent
ma'am.
or palpitations they are experiencing,
Hmm.
postprandial is there or not. Then
Yes,
again for
ma'am.
secondary Parkinson, what is their occupation? That is very important. Okay, so
Yes,
their
ma'am.
occupation you have to ask, and after that you have to ask regarding family history as well.
Yes, ma'am. Family history in young onset and juvenile onset Parkinsonism.
And along with
Yes.
that, hallucinations. Whether they are experiencing any hallucinations, whether there is any fluctuations in symptoms or not.
Symptoms. Yes, ma'am. Yes, ma'am. For DLB.
Be
Yes.
over days, not over only within the daytime or within one day or hours. So they should be within for days. There is there fluctuation or not. So these
Yes,
things for
ma'am.
Parkinson and secondary Parkinson's, we have to ask from them. Okay.
Hmm. Yes, ma'am. Yes, ma'am.
Okay. Go ahead.
Uh,
Please don't forget the drug history. No
yes,
Yes, sir.
matter
sir.
what
Drug
time we say.
history.
Yeah.
Drug history like antipsychotic drugs or intake of these anti-emetic drugs like metoclopramide for longer time, and the
Mhm.
history of typical antipsychotics, and sometimes atypical antipsychotics can cause drug-induced Parkinson whenever given, and the history of toxins, especially in villagers, like history of pesticides exposure, we can ask for.
Yes. One more thing. Can you tell me what is the impact of antipsychotic for on the Parkinson? I mean,
Uh,
like whether it induces, whether it unmasks, what does it do? Or whether it worsen, what does it do?
it can induce and as well as it can unmask, ma'am, and it can deteriorate the Parkinson
Can,
symptoms.
can your unmask, it can induce, and it can your this thing. Along with that, amitriptyline
Person.
as well. It is very commonly used.
Yes, ma'am.
Low backache, because these patients are chronically having this low backache, so that are very commonly prescribed with this amitriptyline or TCA drugs. So they are
Yes.
also induce unmasking or inducing your Parkinson. So that amitriptyline should also be asked in this patient. Okay.
Yes, ma'am.
Okay.
Yes.
Or the other thing we need to remember is drugs for vertigo. People will be on Vertin for months
Yes,
together.
sir.
Sometimes will
Mhm.
taking Stugeron or Diligan or all those things. So
Yes.
Sinerzine again can cause Parkinson-like symptoms. That is something to remember.
Yes, sir. Yes, sir.
And remember
Mm.
that patients, just looking through a patient's old prescription is not enough. many a time they'll be getting over-the-counter drugs, especially these antiemetics. They'll tell you that, oh, I'm just taking something for my gas. We found out
Huh.
something, it'll be either levosulfurate or etopride or something like that. So
Yes.
always doesn't matter, not just the prescriptions. Please ask them to bring whatever medication they have at home, look through it and see if there's anything missing. These any of these, these culprit drugs are there. That is something
Yes.
which can be very, very, very useful.
Yes, sir. Yes. Uh, sir, I think
Yeah.
history part is over. We can move to the examination part.
And Dr. Nidhi,
No,
one
no.
more.
See, yeah, please, Dr. Samir.
You have to ask regarding the cognitive symptoms as well. Okay, in
So,
history, it is very important to ask regarding their what is the current functional status, whether they are having any dementia or not, and you have to rule out the red flags. These patients
yes,
gradually
yes, ma'am. Red flags for atypical Parkinsonism. Yes, ma'am.
subcortical dementia because they start developing the subcortical dementia. So whether they are developing along with the Parkinson, whether they are developing any dysexecution, attentional deficit, and later on,
Attention. Hmm.
yes, later on the
Yes,
developed
ma'am.
the fully developed spectrum of dementia. So that part must always be taken in history. Okay,
Yes, ma'am.
and
And one
third,
uh, part we
men-
can that is will be in examination, that is UPDRS score we can take, and we can take it for follow up purpose also, ma'am. Okay, we can compare the UPDRS scores on so we UPDRS scores involves the history parts as well as the examination parts. So various history parts we can ask from the patients, like any difficulty in swallowing, or any difficulty in dressing, or turning in bed, or any difficulty in walking or maintaining balance while turning, or getting up from chair, getting up from bed, like this part.
disclaimer.
That's true, Dr. Idi. But remember that UPDRS, most of the time, it is a research tool. You will not be using, it is not going to be a long-term usage tool. It is only a research tool. And many a times it is useful only if you're planning like advanced therapies and things like that as a marker. So for what of the time, most of the thing that you need to look at is how is the patient's activities of daily living? How is their independence? You should be
Yes.
able to get that in the history as well. How the if they're having symptoms, what is affecting in their life? Because that is your role as a neurologist. You have to be able to figure out what is the problem, how can you treat them. So just because somebody is having mild Parkinson, but they're absolutely normal, doesn't mean we need to put them on medication immediately. We can
Yes,
wait
sir.
till the
Yes,
because
sir.
we don't have disease modifying therapy. Remember that most
Yes,
of these
sir.
conditions do not have disease modifying therapy. Your
Yes, sir.
only role
We
is
have only
symptomatic. So we need to
symptoms.
recognize, yeah, we are only treating them symptomatically. So can you
Yes.
recognize what the disease problem is and how it is affecting the patient, how you can make it better. So knowing where the problem lies, where what it is affecting the patient with, will actually help you decide what will help. If the only problem is sleep, you don't have to put them on Syndopa 3 times a day or anything like that.
Yes.
The only problem is sleep, just treat the sleep.
Yes.
That's all they need. So they
Yes.
try to figure out where the problem is. And the red flags, again, asking the red flags, when you're asking, we know the red flags. When you're asking history of red flags, remember to ask about urinary incontinence.
Yes,
So
sir.
that is very
Urinary
common in
incontinence.
incontinence and stool incontinence. Sometimes
Yes, sir.
both can occur together. And we're talking about MSA, the other thing is the postural hypotension. The patient won't tell you postural hypotension. All they will tell you is, if I get up, I
Dis-
feel dizzy. I
Dizziness.
get
Yes.
up, I feel dizzy.
Yes, sir.
That's why the patient would have been on Vertin. Because they would have gone to their GP and told, I feel dizzy, they would have started Vertin.
Yes, sir.
Okay, so if you see Vertin in a prescription with Parkinson,
Hmm.
always make sure rule of they don't have orthostatic hypotension also, because that could
Yes.
have been the reason this was started. So take it that away. Of course, many a time what happens is there's this pushing sensation. People complain as dizziness, they get put on Vertin. So that
Yes.
so that is again you have to take that away. You have to remove that from the prescription. Remember that. But when you tell the patient, so when you ask the patient, find out if it's actually a pushing sensation or they actually feel dizzy and lightheaded when they stand up. So that symptom you will have to ask them when you get the history, so that will help you look towards, okay, is the patient having autonomic symptoms more? Of course,
Autonomic and
erectile dysfunction. Yeah,
ATP.
yeah, exactly.
ATP.
So that you can get. And so when and for PSP, when you're asking about PSP symptoms, there are a few good clues. Recurrent falls. Again, the recurrent falls is a
Current
very, very
fault
good sign,
begin. Yes, sir.
especially if they're
Early.
falling backward.
Yes,
Especially if
sir.
they're falling backward. So try to get the history of they're giving a say they will say, no, no, I just slipped and fall. They try to force them. When you fell, what happened? They say, no, 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 I just it was wet, I slipped and fell. Ask them where they slipped and fell. If they're saying, no, no, I slipped and fell in the hall, that's unlikely. In the bathroom, maybe yes. Or if it
Yes,
wasn't
sir.
when they were turning. So try to get the history of each fall, what they were doing, what time of the day it was, and how they fell. We can get those histories that will again tell us whether it was due to hypotension induced fall or was it an actual partial instability fall. So it will push you more towards a PSP versus an MSA as well. So
Yes, sir.
those are things that will help you. And
Yes.
they'll say, I have difficulty climbing downstairs, especially in PSP. So when they feel unsteady when they're falling climbing downstairs. That is a good clue because of their vertical gaze palsy. So those
Vertical.
is again, yeah, vertical gaze impairment. So that is again a
Mm.
good history. If you can get that history, it's useful. Reading, they'll have difficulty scanning, reading down a page. They say, okay, I start reading, I can't read the whole page. I have to stop somewhere because they'll again not be able to code down. So those are all things. If you can get it in the history, it will be a very good clue parking towards. And if they have hypersalivation, there you can sometimes they have to commit the towel around their neck because they are drooling so much. That
Yes, sir.
again is a sign. Is that this is
And
yeah, PSP, because
and
PSP they will have a lot of drooling happening
okay,
because
sir.
of the excessive rigidity. So those are signs. If you can get those signs or get those clues in history, they will push you towards the atypical and the other Parkinsonian syndromes. For of course for CBS, you can if they say asymmetric, that's what
Asymmetrical involvement, sir. Yes,
lasting
sir.
more than 2 3. Of course, by idiopathic Parkinson is again asymmetric. That is what you have to
Yes,
remember. It starts in one but spreads to the other. Something which remains asymmetric for years together, you have to think of CBS. You also have to keep in mind the patient might have say extremely difficult using things. This out of proportion difficulty. So think about slowness. Yes, slowness is there. A bit of clumsiness. Yes, it's extremely difficult to do things. Then you have to think, okay, maybe he has apraxia more than
Yes,
actual, not more than. So if you think the dysfunction is more than just what rigidity can cause, then you have to think of apraxia. So those are all
yes,
clues that you should keep in mind.
yes, sir.
Yeah.
Yes.
So somebody's also mentioned about past history of stroke and head trauma. Yes. So those are things that we have to keep in mind because we know that head trauma can lead to Parkinsonian-like syndrome, especially with chronic multiple head injuries or with SDH, bilateral SDH can present as Parkinsonism. And so, of course, we do have vascular Parkinson. The thing to think about vascular Parkinson is the symptom is as a stepwise progression. If we have a stepwise worsening of through the years, then we have to think of vascular. Many a time we will not get that history because patients will not be able to recall it. But if we are
Mm.
lucky enough, we may get that history. Yeah.
Yes, sir. But sir, like is the like patient is suffering from diabetes and hypertension and also having complaint of only problem in walking, no involvement on upper limb, then we can suspect the vascular type of Parkinsonism.
Yes, but that also does not make it vascular. We also have to think about NPH because
Huh,
walking alone
NPH,
will be
yes,
the
sir.
first thing in NPH as well.
NPH, yes, sir.
And also
And
in some subtypes of PSP, because of the PAGF variant, you will have nothing except the gait falls, gait freezing and difficulty walking. So that's again something to keep in mind.
yes, sir. Yes.
So we
Yep,
have
please go ahead.
concluded the history part. Can we
Yeah.
go for examination? So Dr. Dhanya, you can present your examination.
Sir, shall I share the
Yeah, yeah.
sir? Visible, sir?
Yeah, it's visible.
Good evening, everyone. So till now we have covered the history part, what to be taken. So once we're going into the examination, first, initially, when starting the general examination, head to toe itself, we have the few findings on general appearance. In the general appearance itself, we know the patient may have the mask-like faces, reduced blink rate, along with that, hypomimic face will be there. And in few conditions like PSP, if we see, they may have this astonished look, which and along with that, omega sign can be also seen, like because of the overactive of the frontalis, and
Dr.
procedure sign.
Ganya, that slides are not visible.
Okay, sir. I'll just go. Okay, sir. So before going into it, examination, first we should know the handedness. After handedness, cultural, educational, and work background, and we should definitely know what is the language spoken, and level of consciousness and cooperation. So in general examination, so as I told, physical appearance, behavior, emotional state, and posture is very important. And pulse, BP, blood pressure is definitely very important. We have to check the supine BP, sitting BP, and standing BP. When there is a drop of systolic 20 and diastolic 10, that is considered as a considerable drop, which helps us to know there is an autonomic dysfunction.
Doctor,
And
this is not visible. Your
not
slides.
visible.
Yeah, please.
I've been sharing. It's visible, ma'am.
Yes.
Yeah, please.
Oh, sorry. I'm so sorry. Physical appearance, and then behavior, emotional state, as I told about the blood pressure. So general examination, they may have this mask-like faces. In PD, we see that. And drooling of saliva, as I already told, for the PSP patients, they'll have continuous drooling of saliva. And drinking, there is a decreased blink rate. Normal, it is 12 to 20. And for PSP patients, they may have this blepharospasm, like they will not be able to open the eyes. And less commonly, we also can observe eyelid opening apraxia. And for PSP, as I told, they'll have this astonished look or surprised look because of the overactive frontalis, will be able to see. And dirty tie sign or omega sign. In dirty tie sign, because they are not able to, their vertical movement is restricted, they're not able to see the down, because so when they are eating, they're not able to maintain the they'll be very clumsy eaters, and they'll have the foot fallen. So that is dirty eye sign. And omega sign is because of the corrugated supercilii overactivity. And procedures, there are this is also kind of a focal dystonia, both horizontal lines seen near the eyebrows, and staring face, which favors the PSP. And also in PSP, they'll be having the retrocolis. Immediately when seeing a normal IPD patient, PD patient, they'll have a stooped posture, and they'll have the head bent towards. But in a PSP, when we see, they'll be like keeping their head back. So the retrocolis is seen. And in MSA, they may have this oromandibular dystonia or facial dystonia. And Mason sign will be examining. In emotional state, PD, in PSP patients, they'll have this emotional incontinence or pseudobulbar effect. So for a small, when they're talking or when they're they'll smile, laughing unnecessarily, or crying too much. But they may also have apathy. And PD patients and MSA patients usually present with depression. So posture, in MSA, we usually see the camptocormia, bending of the spine, or dropped head or bent spine. And also there can be a laterocolis, which is called Pisa sign, which is seen in PSP and MSA. and anthropolis is mostly seen in MSA and retropolis in PSP. This alien limb phenomenon or limb contracture. So usually in CBD patients, they may have the dystonia and this alien limb phenomenon. This alien limb phenomenon can be like either it's a frontal, parietal, or callosal hand, which is commonly seen in CBD. In frontal, they will be like grouping, unnecessarily grouping of the things. In parietal, they will not recognize that as their limb. In callosal, there will be an intermanual conflict. So one limb will be doing and the other limb will be doing the opposite action. And we also see in MSA, usually the striatal toe will be seen. So this we can see the retrocolis, and this is the Procerus sign we can see here. So dystonia and striatal toe we can see in this. So going into higher mental functions, MMSC is must to be done. And MOCA is also advisable, and FAB is must because we have the frontal lobe problems which we seen like in PSP. There will be an attention deficit, executive function, and fluency abnormality. And in PD, bradyphrenia means the thought itself, the slowness of thought will be there. And for CBS, mostly we'll be seeing apraxia. And visual function impairment is most commonly seen in DLB and CBS. And PD also we can see episodic memory. And neuropsychiatric abnormalities most commonly seen in PSP is emotional incontinence and apathy. And depression and anxiety is also seen in other conditions. So this is the assessment for the MOCA and mini mental state examination. So for visuospatial, we'll be doing the trial B, and the clock drawing will let us know if they have the alien limb. In CBD, we can see the clock drawing will be abnormal. They'll be drawing only on the one side, keep the numbers only on the one side, like that.
Actually, you're
Okay.
getting it wrong, doctor. That is actually for neglect. So drawing it on one side is neglect. They'll have executive dysfunction. The clock
Okay,
drawing
sir.
is an excellent test which will pick you up executive dysfunction. Executive
Okay, sir.
dysfunction is important because that is the first cognitive impairment in any Parkinsonism. Doesn't
Yes.
matter the subtype. Even in idiopathic, executive dysfunction is what happens first. The planning is
Okay, sir.
lost. So they'll have difficulty in
In
doing
plan.
placing the letters properly and in finding out where to place the how to share draw it together. So that's why that is very important early on.
Okay,
Of
sir.
course, if you have visual spatial dysfunction in DLB, so that
DLB,
might
we will
again
be
be
seeing that.
so
Yes.
so that again the drawing again the whole structure will be completely gone as well.
Okay, sir. So, so attention will get by doing this like number forward and tap test. We'll get to know the attention and abstraction and language as well. And delayed recall will know about the memory impairment. So in as I already we have discussed attention, orientation, and concentration. Uh, the test for attention will be number of days in a week or months in a year, or attention vigilance, random letter cancellation, or serial subtraction test. And trail A also number of like they will be able attention and processing speed. Trail A test will help us to know within 30 seconds they should be able to complete it, 27 to 30 seconds. And in language, how is the spontaneous speech, followed by how is the fluency, comprehension. So the how is the language affected in different thing, it is there in the next slide, sir. I'll tell that. So memory and executive functions, and for testing the parietal lobe and testing the occipital lobe. So for the speech, in the PD patients, usually it is a slow, monotonous speech, or sometimes, or it can be a fast, festinant speech. The pitch will be very low, hypophonic. In fact, it will be the most common the presentation, and articulation may be imprecise and may or may not have the palilalia. And PSP patients, it is slow. The strained quality, and as you have the pseudobulbar palsy, they may have the spastic quality. It is a slow, effortful speech. And in MSA, we have the speech rate is variable, and this is mainly associated with stridor or hoarseness. And if it is a MSA C and C type, the cerebellar component will be there, so they may have the scanning type or ataxic type of speech, slurred speech. And fluency, there will be occasional interruptions. In CBD or CBGD, they'll have slow, halting speech. It is flat, effortful, and irregular pauses. They may have the speech initiation difficulty or agrammatism, so it's called apraxia of speech, which is seen commonly in the CBD. So going into the cranial nerves examination, first olfactory. This hyposmia, anosmia is mostly seen in synucleopathies, because the alpha synuclein is accumulated in the olfactory body and tract, but it is not seen in PSP or CBS, which is a tauopathy. Next, optic nerve and 3, 4, 6 cranial nerve is discussed in the next slide, sir. So for trigeminal, for the PSP and CBS, we may have the jaw jerk, brisk jaw jerk, and decreased corneal reflex in the PSP. Facial, we may observe blepharospasm, and for glossophary, MSA and PSP, 9, 10, 11, 9, 10 cranial nerves will be affected. So in PSP patients, there will be early dysphasia, and for MSA, it will be very severe dysphasia. This effect will be there in very late stages of the normal PD. Dysphonia favors MSA, stridor also favors the MSA, and hypoglossal nerve, 12th cranial nerve involvement, in MSA, they may have the tongue atrophy and fasciculations. So for eye, there is a decreased blink rate, as we discussed already. Crossier's sign will be positive, and abnormal gaze, which is seen mainly in the PSP. There will be a vertical gaze restriction will be there. Actually, as the age progress, upward gaze may be slightly restricted in everyone, but so downward gaze is more typical of PSP. And there will be abnormal saccades. So mostly there will be slow saccades. Horizontal saccades is abnormal. So because of which we see this round the house sign. Because of the abnormality, they will go to the lateral side and come down.
Actually, doctor, that is the vertical saccades are abnormal. That is where you get the house around the house sign, not for the horizontal saccade.
Sorry, sir.
Yeah,
Vertical.
sorry. Yeah, and for the especially, and you mentioned about the gaze being impaired in PSP. That's true, but the first thing to get affected is actually saccades.
Slow saccades.
First thing is always saccades. After that, over time, it becomes gaze.
It will become. Yes, sir. Yes.
Okay.
Okay. So abnormalities of the pursuits will be seen in very late, sir, and OKN also will be affected, sir.
Is very important in this hypokinetic disorder. Actually, this pursuit pathway involves a cerebellar involvement. So in patients of MSA, the pursuit involvement is very common to see. It's very early. The pursuit should be carefully, both the horizontal as well as the vertical pursuit. Okay, so there will be the open pursuit, or there will be a yes, open pursuit will be there, and OKN must also be checked. That is also abnormal.
Okay.
And saccadic, in all saccadic, you have to see all the aspect: the initiation of saccade, the amplitude of saccade, whether they're hypometric or hypermetric. So the speed of saccade and any end saccadic this corrective movement or not. Then anti-saccade as well. That should also be checked, whether they are doing it completely wrong or whether there's a pro-saccade followed by anti-saccade. So the saccadic and pursuit movement in every patient of this extrapyramidal this Parkinson very carefully should be checked. Okay.
Okay. So this is normal gaze. So for checking the normal gaze, we have to slowly trace the letter H for the patient to follow. Some add the primary gaze plus up gaze and down gaze in the center to make the 9 cardinal positions. So eye movements should be smooth and conjugate throughout. The 6 cardinal positions are designed to search for the dysfunction for individual muscles or nerves, as well as the supranuclear abnormalities. Assessment of the up gaze and down gaze in the primary position assesses the supranuclear vertical gaze movements mechanism. And for pursuits, we have to ask the patient to follow the target held 0.5 meters to 1 meter away, and such as examining a light or a pointer, a pen, or an examiner finger. A linear target should be held perpendicular to the direction of the gaze. Vertical, testing this horizontal gaze, and horizontal for the vertical gaze.
Dr. Dhanya, can you enumerate all the supranuclear movement that to be checked?
Pursuits, saccades, next,
Yeah. Next. So it's two type of movement. One is your this conjugate movement, and another is disconjugate movement. Okay. So in conjugate movement, it's your saccade, pursuit, and OKN. And for disconjugate, you will check for vergence,
yes,
convergence, and the divergence, and then
Divergence.
finally last that to be done. Okay. Please continue.
So assessment of the up gaze and down gaze is occasionally difficult because as we normally ages, impairment of the up gaze can be there, which varies from individual to individual. So as we already discussed, vertical gaze will be impaired in the early stages of PSP. Down is more involved than the upward. And horizontal gaze usually mildly impaired in PSP, normal or slightly slow in PD and MSA, CBD, DLB. So reflexive eye movement, VOR also initially preserved in the PSP, but later VOR is also affected. So saccadic velocity, I think we have discussed this, ma'am. Shall I move forward? So saccadic accuracy will be, velocity will be mildly slow in PD, but severely slow in PSP. And saccadic accuracy will be hypometric in a PSP. And square wave jerks are also seen frequently. And pursuit quality is severely impaired. There will be a catch-up saccade. So saccadic pursuits will be seen. And fixation stability is frequent. And OKN response will be absent in the PSP and impaired impaired in the DLB. So going into the motor system examination, so we'll be checking tone, power, coordination, rapid alternative movements, involuntary movements, and pathological reflexes. So tone, for checking the tone, first we have to check the axial tone and appendicular tone. For axial tone, neck, trunk, and shoulder shrugging. So we'll make the patient turn backwards and check for the truncal axial tone. Later, appendicular tone should be checked among all the joints, across all the joints and all the range of motions. There will be cogwheel rigidity in IPD patients and lead pipe rigidity in PSP and MSA. So it is asymmetry favors IPD, and asymmetry is also seen in CBD. It will be MSA and PSP, DLB, usually it is symmetrical. And if we are not able to, it's better to do a Foreman's maneuver while checking the rigidity. So it will unmask the subtle rigidity. We'll just ask the patient when we are checking the right hand, the left hand limb, we'll be asking them to move and concentrate on the up like roof. So it will unmask the subtle rigidity. So there can be a paratonia, Gegenhalten phenomenon. And in other conditions, like in vascular Parkinsonism, these conditions, there will be an increased lower limb rigidity compared to the upper limb rigidity. And the axial rigidity is more than the appendicular in PSP patients.
Yeah. Can you elaborate, Dr. Dhanya, how to check for axial rigidity?
Ma'am, we'll make the patient stand, we'll go backwards and we'll hold the shoulders and we'll try to move move him.
Yeah, actually, keep your both hands on his shoulder, on each shoulder, and then try to shake them.
Shake.
That's how you have to do that. That's a shoulder shaking test. So that's how you should check the axial rigidity along with the neck examination. Okay.
Yes. So for checking the power and rapid alternating, power usually it will be normal, but there can be an asymmetrical slight in the reduction in the CBD. And bradykinesia may be misinterpreted as a decreased power if it's very severe. So rapid alternating movements. So the rapid alternating movements will be checking for like fatigability or slowing on repeated movements. So when we are doing, we'll be checking for three parts. One is rapid finger tapping, rapid hand opening and closing, and for legs it is heel or toe tapping. And for legs we can also ask them to draw the 8 with the toe, and check for the symmetry or asymmetry. How is the speed of the movement? How is the amplitude? So there is a decrement in the amplitude while tapping. That is more that is more what we'll see for the bradykinesia patients, and the range of movements and change with the time.
Actually, we are
So
looking at both decrease in speed as well
speed
as
and
amplitude. So
okay,
because
okay.
fast we want to make up fast, but slow, means smaller amplitude is actually what we see in predominantly in PSP. But we have to look at for trying actual bradykinesia, we need reduction in speed as well as amplitude.
Okay, sir. Okay. So for coordination, dysmetria, dyssynergia, or intentional tremor, usually for so for checking for the other tremor, it can be a rest tremor, postural tremor, intentional tremor, or orthostatic tremor. Rest tremor is when patient kept the hands rest at on the legs. We'll be observing. Postural, when the posture, when they attain a particular posture, when they may have the postural tremor. And after attaining the posture, after some time, after few seconds, if the tremor is present, after if tremor comes, it is re-emergent tremor. Or also they can have the intentional tremor is seen in cerebellar component, and orthostatic tremor. And we'll be checking for the heel shin test, tandem walk. For pull test, we'll stand behind the patient, and we'll have a behind the wall. We need to have a support of the wall, like so. When we pull the patient, normally within 2 steps they will be they usually not fall backward. Within 2 steps they'll maintain the stability. But if it is more than 3 steps, it is abnormal, or sometimes they may fall backwards. That is severely impaired. And for ataxia, we'll be checking, and severe early postural instability, which it favors the PSP. And
So just
sir,
hold that.
I'll tell the gait again. There is
Just hold there. One thing.
yes, ma'am.
Yeah. First thing regarding the tremor examination. So the tremor has to be also checked in detail. So first you will make the patient to keep his hand on his lap
Like
against activity in the resting position. At
yes,
that time, you will notice whether there is any tremor or not. Okay,
yes,
one thing. Second thing, this postural tremor to be noticed in the outstretched hand.
oh, yes, ma'am.
In the outstretched hand, you will look for in the Parkinson, there is a suppression of those resting tremor, and after some time, there will be again a re-emergence of a tremor that is called as a re-emergent tremor.
Yes, ma'am.
Okay. And later on, when the condition advances, they can have both the resting as well as a postural tremor.
Yes,
Okay. And later on, and after that, you will ask the patient to extend his shoulder and to flex his elbow.
okay.
And then you can look for whether he is developing tremor at that time or not. So both the component of postural, outstretched head as well as you
And
check for
yes,
the
okay.
you have to do that in that position also. And for last, it will be the intentional tremor.
Yes, ma'am.
And on history, you will also ask whether there are any exhibition of tremors during anxiety or not. So that will again give a clue regarding a component of the patient has started developing the this postural tremor along with the resting tremor. Okay.
Oh, yes, ma'am.
Next, regarding this tandem walk pull test, this all comes under gait examination.
Okay, ma'am.
So when you will describe the gait, at that time you will describe all this examination.
Sure. Okay.
Okay. And in that gait examination, it should be complete from starting from the patient when he's rising
From
from the
sitting down to getting up from the chair, from there.
getting up from the chair, the complete walk, and then followed by the turn, and
Yes,
then tandem walking, and then the pull test.
yes, that is covered in next slides, ma'am. I'll tell.
Yes, definitely. Continue.
So yeah, other involuntary movements also to be definitely checked. So foot dystonia is seen in young onset PD, and drug-induced dyskinesia, and dystonia is also seen in CBD, unilateral the twisting movements. Dystonia will be seen in CBD patients, and myoclonus in CBD patients. It is like in MSA, it is
Yeah,
polymini myoclonus, and
in
CBD
CBD, you'll
tactile.
have you'll have a cortical myoclonus. So
Yes, a
there's a lot of
cortical
touch sensitivity.
cortical. So
Yeah,
we
touch
have to check with the
sensitivity.
pinhead when with the outstretched hand with the pinhead, like they kept the like hands on the legs. If we do the pinhead, touch with the pinhead, they will have the myoclonus.
You can do it
So
by just tapping. You don't need to have a pinhead. For the
okay,
tactile so tactile sensitivity, just ask them to outstretch the hand, close the eyes, and
and
just tap it and see if there is
tactile
jerks happening.
hands. Okay,
Just tap the hand. That's all you need to do. Very simple. And sometimes you can also look for auditory jerks. That's very rare. Cortical myoclonus, usually its tactile sensitivity is very common.
yes. I have other PPT after this, sir. I'll just share that once.
Excuse me, sir, ma'am, can I ask one question?
Yes, please ask.
Ma'am, should we inform the patient before pulling test कि
Yeah,
we are doing this test and you will manage accordingly? Should
yeah,
we
yeah.
ask?
Before doing any test, you have to explain the patient. So
Okay.
whenever you are,
So,
please continue, sir.
no, please, ma'am. We are talking. Please finish it. I will add on later. That's right.
Before doing a pull test,
Mm.
actually, you have to stand against the wall, and after that, you will just make the patient 2-3 steps ahead of you, and you will keep one attendant as well nearby them, and you will explain the patient that you are going to pull them backward. Okay, and after that, you will just do the test.
Yes, ma'am.
One more thing you can tell the patient this, you have to tell them first thing, ask them to keep a wide stance. Especially standing in nanostance, they'll definitely fall. Ask them to have a wide stance. Tell them you're going to pull them back and tell them try not to fall backward so that they can try to correct themselves. Otherwise, they think that they are meant to fall back and you just lose it. So ask them they need to try to correct their stance. If necessary, they can take 1 or 2 steps backwards so that they won't fall like a stone because that is very dangerous. If it happens like that, they'll get injured. You may get injured as well. They can take a couple of steps to correct themselves if they want, if they are not able to balance themselves. Tell that and then pull them back. So in classical instability, what will happen? They'll keep step and they'll just keep coming back. So that's a good sign. In PSP, they'll fall like a log. They'll pull and then that's it. They just fall directly. That's a very good sign that that's more likely PSP than PD.
Okay, sir. Okay. Thank you.
So going into the sensory examination. So in the sensory examination, like we'll do the normal crude touch, pin prick, temperature, fine touch, and vibration. Once the normal sensations are normal, we have to check for the cortical sensation. In cortical sensation, we have stereognosis, graphesthesia, and 2-point discrimination. Stereognosis, we have to give the familiar objects like coin, key, pen cap, or other things, and we'll ask the patient to close the eyes and keep them as object in the hand and ask them to guess what it is. And graphesthesia, any they will ask to will write with the hand on the palm like numbers or letters, whatever the language they know, and or in the dorsum of the foot. So with eyes closed, they have to guess it. And for 2-point discrimination, we'll take a divider and eyes closed, touch with the 2 points simultaneously. Ask how many pins they are able to feel, like prick to him. So for fingertip, it is 2 to 4 mm, and palm it is 8 to 12 mm. Dorsum of the foot it is 30 to 40 mm. So this is mainly seen. The cortical sensations are lost. Important for the like CBD patients, there will be loss of cortical sensations on one side, and so this they and also seen in vascular Parkinsonism if they have any multiple infarcts and all. And for reflexes examination, deep tendon reflexes, there will be it can be exaggerated or asymmetrical or reduced reflexes. and superficial release reflexes are the main emphasis. So
No. Your deep tendon reflexes are equally important. See, the multi-system atrophy, the name itself has given to the multi-word. Okay.
it will be exaggerated, ma'am, in multi-system atrophy.
So exaggeration of reflex, if you are getting, you should check for the atypical Parkinsonism.
Yes, ma'am.
Is it MSA? Okay. So that exaggeration of reflexes and asymmetry are equally important.
Oh, yes, ma'am. Asymmetry will be seen. Okay. So the release reflexes are seen like grasp reflex, utilization behavior. Like grasp reflex will try to keep in the near the palm. They'll try to hold it, or in the utilization behavior, if whatever kept near in front of them, they'll try to catch hold of it. And for snout reflex, will just on the philtrum of the upper lip will they'll have the puckering of the lips. For circling and rooting reflex, when we try to tap near the lips on the side, they'll start sucking. Or for glabellar reflex, which we check for, will go stand behind the patient and tapping on the forehead. There will be continuous normally after 2 to 3 taps. They'll stop having this. Uh, the reflex normally, but these patients, they'll not in Parkinson's patients, it will not stop. And palmomental and avoidance, palmomental reflex is mainly seen in when we are tapping on with a blunt object on the thenar eminence. There will be dimple, or in the chin region. It is mainly seen in the diffuse cerebral damage. And so So, so gait examination. For gait examination, we'll ask the patient to sit on the chair and ask to stand from the sitting and stand, and then we'll ask them to walk, take turn, and other maneuvers. So from the start, standing from the sitting, usually proximal muscle strength should be normal. The hip and knee extensors. So the trunk and the limb movements also should be normal. For PSP patients, when they are standing from the sitting position, normal PD patients, they will have difficulty in getting up. They will try. They will take some support, or they'll have 2 3 tries, and slowly they'll get up. For PSP patient, they'll get up as if like very fastly, and they'll fall down. This is this is called rocket sign. And for MSA patients also, there will be mild postural instability when they're getting up. And compared to stance, for MSA-C patients, once they get up, they'll keep the feet wider. And in standing position, trunk posture, in PD patients, usually it is flexed and stooped. And in MSA, we'll be seeing like a camptocornea or antrocholis or laterocholis. And stance base will be normally, it can be narrow or wide. In CBD or MSSC, we'll be seeing kind of wide. And body swaying can be there. And Rombox test, we'll do once they stand. We'll do the Rombox test for the sensory, this one. And tandem stance. And now we'll do the pull test, followed by we'll ask them to the walk. Their initiation of the stepping, once we ask them to walk, there will be a difficulty of the initiation of the stepping. It's called start hesitation. Or for NPH patient, they'll not be able to move the step away from the floor. It's like the foot is glued to the floor. It's called magnetic feet phenomenon. And stride length will be reduced. We have to check for the stride stance base with cadence. It's like how many steps they are taking in a minute, the rhythm of the step, and tempo of the stepping. The step trajectory should be checked. And associated limb movements, like the arm swing will be reduced while walking. And how is the trunk posture after walking for some time? Is there is any freezing of the gait? Like start, they'll have a when there is a narrow pathway, they may freeze. Or if they have any obstacles, they may freeze. and after coming to 10 meters distance, they have to take a turn. While turning, normally we will turn with one like the with normal turn, but in they can be a freezing, like they will not be able to turn, or the en bloc turning will be there. They will have some 3 or 4 steps while taking turn. Or pivot turn is like with one flow, 1 foot support, they'll be having a turn. Other maneuvers we'll be doing here is tandem walking backward. Walking backward helps us to find out the dystonia. When there is a dystonia, while walking they may have difficulty, but walking backward will be improved if it's because of the dystonia. And running, walking on toes and heels, and check for the striatal toe. So for posture Parkinson's patient and symptomatic Parkinsonism, the difference, posture will be stooped, and others it will be stooped or upright. Stance, it will be narrow in Parkinson disease and often wide based in other Parkinsonism condition. And there will be a start hesitation in Parkinson disease, and others like start hesitation in magnetic foot as in NPH, and small shuffling steps. And the stride length will be short in both, and freezing is common in both. Leg movement will be stiff and rigid, and speed will be slow. Fascination is little, it's more common in the Parkinson disease compared to the other Parkinsonism. And arm swing will be minimal or absent. And even the arm swing, one difference we can see in CBGT patients is like one side arm swing will be reduced and one side they'll have normal, where the and heel to toe walking will be normal in Parkinson's. Who have the truncal ataxia, it is poor. Like in PSP, it is poor. And the postural responses will be preserved in early Parkinson's, and it is absent in the symptomatic Parkinsonism. Like how I told, for PSP patients, when they're getting up from the chair, they'll not be able to maintain the balance because of the loss of this postural reflex. They'll fall down. And falls will be very late in the Parkinson's patient and early in the Parkinsonism. For PSP patient, is usually backward, and MSA patients, usually it is forward because of the orthostatic hypotension. Uh, and as we told, the types of freezing, either it can be at the start initiation, start hesitation, or while turning hesitation, or when they're approaching the target, there will be a destination hesitation. There they can have the freezing, or when they have the obstacle, or when even in the open space, there can be a sudden spontaneous transient freezing. And like even this freezing can be seen even in the speech. And the autonomic nervous system examination is equally important. For MSA patients, when we are suspecting, we'll have this test of so for autonomic examination, the skin texture, piloerection, and so yes, cardiovagal system, heart rate response to the postural change. So 30:15 ratio, like it will be change in the when there is a sitting to standing. And with a deep respiration, with the respiration, there will be a variation. And it will be normally for longest respiratory rate interval to the shortest respiratory rate interval, it will be greater than it will be normal will be greater than 1.07. And for Valsalva maneuver, there will be reduction. The phase 4 is to phase 2. The heart rate should be 1 is to less than 1.2. And for blood pressure drop, as we told, supine and standing, which we can do at the bedside, there will be a drop in the systolic blood pressure more than 30 and diastolic 15. Ma'am, I have a doubt here. Like some places it will be mentioned as 20/10, and some we will be seeing as 30/15. Which we should consider like drop?
MSA it is 30/50.
So if you look at the criteria, there is a variation between definite, how significant the partial drop is. 20 is maybe it becomes counter possible, where it becomes more than 30 becomes probable. That's where it's a difference. But always look for any difference.
isometric exercises, there will be, when there is a maximum grip for 3 to 5 minutes and check for the BP for after 1 minute, there will be normal rise of diastolic blood pressure greater than 15 mm at the end of the exercise, and less than 10 mm raise in the diastolic blood pressure. If it is less than 10 mm raise, then it is abnormal. And cold pressor test will be there. Immerse the arm in the axilla, like up to the axilla. There may be rise in the BP, which it's difficult to check. So other other tests are like, we can check for this povidone iodine can be applied. So with the cornstarch powder is brushed, and there is, when there is a reduce in the sweating, there will not be change in the color. So and for the gastrointestinal and genitourinary autonomic function, we can check for the superficial anal reflex, bulbocavernal reflex, and anal wink reflex. And So, summary of the clinical findings. Symmetry is present in PSP and MSA, and it usually asymmetrical in PD and CBD. And axial rigidity is more in PSP compared to other three. Limb dystonia is seen in CBD. Postural instability is seen more in PSP. Vertical or supranuclear gaze impairment is seen in PSP, and frontal behavior is most common in the seen in PSP. Dysautonomia, MSA, and levodopa responsiveness is seen in normal PD in early in the course, but later in course the response can be little reduced. And asymmetrical cortical atrophy on the MRI and cortical signs can be seen in CBD. So even for the PSP, we have different variants of PSP. PSP Richardson type, Parkinsonian type, PSP of gait freezing, PSP CBS, and frontal variant, behavioral variant of FTD, and PSP-C, Parkinson's disease, and this one. And early postural instability is mainly seen in PSP Richardson type. And in cerebellar type PSPC, early eye movement abnormality, and even in the Richardson type, it will be seen. Cognitive decline is most commonly seen in the PSP CBS variant and other PSP behavioral variant, and this one. And early frontal behavior was also seen in PSP behavioral variant, frontotemporal dementia. And this non-fluent aphasia or apraxia is seen in PSP non-fluent aphasia or apraxia of speech. Limb dystonia is common in PSP CBS variant, and they will have the and levodopa responsive is normal in Parkinson's. In others, all other atypical, levodopa responsiveness is not there. And dysautonomia is common in MSA P type.
One small variation, doctor. You have to
Yes,
remember
sir.
that PSPP early in the
Yes, sir.
disease will show response.
Oh,
It
okay,
may
sir.
be there will be a mild asymmetry. Patient will look very Parkinsonian. So there will be mild response. But of course, the degree of response is what
Will
matters.
be less.
The
Okay.
sustained response and the degree of response is what helps you differentiate between PSPP and Parkinson, idiopathic Parkinson. That is why we ask always that the patient has to be followed up for a minimum of 5 years
5
before we
years.
can brand it as idiopathic Parkinson.
Yes, sir. So, like, even, okay, sir.
Yeah.
And PSP eye signs, as we already discussed, to summarize, earliest is the square wave jerks, and eye oscillate horizontally across the midline during the visual fixation, and slowing of the vertical saccades with or without round the house sign. And round the house sign is the curved trajectory of the vertical saccades. For supranuclear gaze palsy with restriction of the range of vertical gaze, and pretarsal blepharospasm, apraxia of the eyelid. So they'll not be able to move the eye, apraxia of the eyelid opening, and visual grasping. So eye deviation and intermittent head turns toward the object. When someone is walking forward, they'll not able to stop it. So they will have to move towards and see. Bilateral impairment of the anti-saccadic task. And other signs, procerus sign, it's a focal dystonia of the procerus muscle. And next, rocket sign, a toppling backward after jumping to the feet from sitting position due to the postural instability. And hypokinetic spastic dysarthria, pseudobulbar features, frontal subcortical type of dementia, These are the main features in PSP. And in MRI, as we know that the morning glory sign is seen. Here, the horizontal line is drawn through the edge of the posterior cerebral aqueduct. A second line is along the lateral margin of the tegmentum from the intersection of the horizontal line to the pit between the tegmentum and the cerebral peduncle. In normal subjects, the lateral margin of the tegmentum is convex and runs outside the second line. This is positive when the tegment is concave and the lateral margin runs inside the second line. So other sign we'll see in the sagittal section is hummingbird sign. Atrophy of the midbrain results in the profile of this, and pons form the body of the bird. Atrophic midbrain forms the head of the bird, and beak extending anteriorly towards the optic chiasma. Wings were formed by the cerebellum. In other one is MRPI and MRP 2.0. So area of the midbrain and the pons are calculated on the midline sagittal image. The pontomesencephalic junction, the line between the superior pontine notch and the inferior border of the quadrigeminal plate. And pontomedullary junction is defined by a line parallel to the first line at the level of the inferior pontine notch. Now, normal value is approximately 0.24, whereas in PSP it is reduced to 0.12. And in MSA summary, to summarize the MSA, dysautonomia, urinary incontinence, erectile dysfunction, orthostatic hypotension, and post-void residual volume greater than 100 ml or orthostatic hypotension. At least at least one of the either a Parkinsonian syndrome, bradykinesia with rigidity, tremor, postural instability, or cerebellar syndrome, it's in MSSE, gait ataxia with cerebellar dysarthria, limb ataxia, and cerebellar oculomotor dysfunction. And in radiologically, we can see atrophy of the putamen, hot cross bun sign, is seen in the T2 axial because of the hyperintensity in the pons. And in other we'll see is a putaminal rim sign because of the hypointense putamen with hyperintense rim. Thank you.
Okay, so one last thing to add is in these MSA signs, there is this hot cross bun because already in naturally you have this median rim between the, because there are two sections of the body, so the both side of the pond there is a median rim is naturally there. But what happened? There is a dysmyelination of what fibers? Cortico, ponto, cerebellum. So because of this dysmyelination, you start seeing a hyperintense rim in the vertical line as well. So this horizontal line as well. So this makes your hot cross bun. Similarly, in this this MSA-P type of variant, there is this, if we see developmentally, the caudate and putamen actually are developed from a single part or a common part. But during the developmental growth, these both get separated, and the passing internal capsule fiber, they actually separate this caudate from the putamen. So in MSA, what happens? This is an involvement of these internal capsule fibers at anterior limb of internal capsule fibers. So when this internal capsule fiber again got dysmyelinated, you again start seeing a rim which was actually connecting the caudate to the putamen. So that's why these two signs develop. Okay.
Okay.
Yeah. And then last, Dr. Dhanya, can you tell me what is kinesia paradox?
Normally, this Parkinson patient, they'll not be able to walk. They'll be slowly walking, but they can run. In spite of
Normally they can't run, but whenever there is any stressful situation, for example, there is a fire or something.
Like,
yes, so
I can tell them.
yes, definitely. So that history should also be asked. And along with that, this is to all the exam going students. Please read about the autonomic function testing in detail. If you're getting any old examiner or anyone who is interested, they will ask you. They will definitely ask you. And you have to do ECG and your autonomic function test in exam. So you should make yourself handy, and whatever 2-3 tests that you can do during the exam, that should be done very thoroughly. So if you start practicing, then only you will be able to train the patient. Okay.
And one last thing, I don't know if I missed this. How do you do how do you test apraxia at the bedside? Or simple screening test for apraxia? How do you do them?
the pantomime. First, we'll check for the pantomime test. we'll check for the knowledge of the pantomime, and we'll ask them to do the to do the salute or namaste, and later we can uh, we'll ask to do how examiner is doing, copy
Yeah.
us one meaningful gestures and meaningless gestures also we'll ask, and later we can ask them to how they will do the combing, how they will do the brushing. So normally if we have to explain them, imagine they have the brush in their hand, hold it and do the brush. In spite of that, if the apraxia is there, they will either they will not show how to do it, or they will substitute the body part instead of the this one.
And so I can also give them a small instrument. I'll give them a pen and see how
Instrument
whether
how
they
they
know how
hold
to
it.
use. That's an easy thing to do at the bedside, or
Yes, sir.
ask them to use secret form. Thing is, you have to test in both hands separately, especially if you're
Yes, sir.
doing a
Yes, sir.
pantomime. Actually, in a patient like with CVS, you might have the apraxia only in one hand, you might
One
not
one
pick it up
hand.
in the
Yes,
other
sir.
hand. So
Yes, sir.
remember to do it in both hands.
Both hands. Yes, sir.
And one more thing, Archimedes spiral.
Yes,
How to
ma'am. For tremors, we will have to definitely check
yes,
it.
the thermal examination that Archimedes spiral to be done.
Yes, ma'am.
Okay.
And remember, to test a resting tremor, to always give them a serious subtraction test or something, do distraction to look for an mild resting tremor, which might not be evident at all. You need to completely relax the patient and ask them to receive some sort of a mental distraction. Then you might get the tremor out. Without
Okay.
that, don't say there is no tremor.
Yes.
So thank you, Dr. Dhanya and Dr. Nick,
Okay.
for this session. Please
Yeah,
continue.
anybody have any question they can ask? So, Dr. Dhanya, what are the bedside autonomic function that you can do? That is the common Viva question.
Okay. So we can check for the Valsalva maneuver. We can check, sir. So patient will exhale into the exhale for 15 seconds and then relaxes. First phase there will be a tachycardia, and second phase there will be a bradycardia, and respiratory ratio will be longest in the second phase and shortest in the first phase, sir. So it
So
will be usually 1:4, which is more normal.
for
And
that, you need to have continuous ECG monitoring. Without that, you
okay.
cannot do the Valsalva. Remember that you need to have
Yes, sir.
RR. You need at least a single lead ECG to be going on when you do the Valsalva. Otherwise, you're not going to get the RR variability correctly. So that is not actually a bedside test. A more important bedside test is the orthostatic hypotension. This orthostatic hypotension and the screening test, as in the mental arithmetic, ask them to do breath holding, and all of that. You can look at heart rate variability and BP variation. Those are the two things
We,
Those are things you can do bedside. Valsalva,
can
yes,
we
but you'll
do
need it for
this
that.
hand grip one, sir? We can do the
Yeah,
hand
hand
grip
grip
for
can do.
5 minutes
Yes,
and
hand
then
grip
check
you
the
can
blood
do.
pressure.
Yes, hand grip, breath holding you can do, and of course, lying and standing. Lying and standing, always remember to do in a completely flat.
Yes, sir.
The patient has to have it completely flat for at least 10 minutes. Then immediately make the patient stand up before and then do it after 2 minutes. There will be certain variation.
Yes.
So just the patient who has been sitting for a long time, just make them lie down and then make them stand up. Then it won't be useful. There won't be much variation. We need a patient who's having complete rest to have a definite variation happen. So
Okay.
these are bedside tests that they can do.
Okay.
Yeah, if there are no further questions, we will close the session. Thank you, Dr. UM Srinivas and Dr. Soumya for moderating this session. And thank you, Dr. Nidhi and Dhanya for presenting. And everybody, thanks for attending this session. We can close this session now. Thank you, everyone.
Thank you, sir. Thank you, sir.
Thank
Thank
you.
you, sir. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, ma'am.